Welcome everybody to this meeting of the Council of Governors for Humber Trust, and welcome today. And in particular, can I take the opportunity as Chair of the Trust to formally welcome some of our new governors, Marilyn, Will and Brian, who are here with us this afternoon. And I just wondered, Marilyn, Brian and Will, I know you've met quite a few people, but maybe you'd just like to introduce yourself, because I know probably Michelle hasn't met you before, Michelle Moran, and maybe a few other people. So let's start with Marilyn.
Hi everybody, I'm the new Governor for Patient and Carers. I'm an off-Cumden really, because I come from Bradford. It's nice to hear somebody's actually there at the moment. I moved here about 15 months ago. Whilst I was there, I was the chair of the Patient Network, chair of Relate Bradford, and did lots of work with the Improvement Academy and so on. So I've had a lot of experience in the NHS, plus the fact I worked there until I was 60 as a counsellor psychotherapist in primary care.
Thanks very much, Marilyn. Brian, are you there? Could you just say hi and introduce
Hello there.
yourself?
I'm Brian Swallow. I'm a retired lecturer in psychology. I taught mental health and health psychology. Prior to that, I was in social work and worked in the voluntary sector as the director of what was then North Humberside mine, and I was in some other voluntary organisations before that. I've been retired for 10 years and thought it was about time to take an interest in something again. So a bit out of my depth with this so far, but I hope I'm learning a little bit, and I hope I'll be able to make a contribution.
Thanks, Brian. Thanks very much. And Will.
Hi, I'm Will Taylor. I'm a clinical psychologist, staff governor in Hull CAMS, and I've worked in Humber in child sort of psychology services in different teams for at least 15 years. Does that sound about right? Yeah. So that's me.
Great, and you're all very welcome, and we also have with us today Steve Duffield from the Humberside Fire Service. Hi, Steve.
Hi, Caroline. Good afternoon, everybody.
And Steve is joining us today, and colleagues will remember Paul McCourt was the previous representative. We have only Steve for a very short time because somebody else is joining the service in the autumn and we'll be replacing him. We really appreciate you attending today, Steve. I know you're very busy.
Thank you for having me. Thank you.
Brilliant, great. Okay, apologies for absence. We have Jackie White, Councillor Abraham, Councillor Chambers, Andy Barber, Sharon Nobbs, Greg Enderby, Joanne Gardner, Tim Durkin, Anthony Hoof, who's also a new governor, and Ruth Marsden and John Cunnington. So those are the apologies. Any more apologies, please? Okay, no, we'll move on then. Declarations of interest. If there's any changes to your declarations, please let Jenny Jones know. And if anybody's got something that they think might cause them a conflict with anything on the agenda today, if you could just let us know, and if appropriate, remove yourself for that item. Anybody need to say anything at this point? No, great. Okay, we move on to the minutes of the meeting held on the 14th of April 2022. Are there any corrections to those minutes, please? No? Oh, no. Any matters arising from those minutes that's not on the agenda? No? Is the Council of Governors happy to approve the minutes of the 14th of April 2022? Yep, everybody's nodding. Thank you very much indeed. We move on to the action log. The action log, as you can see, all of the actions have been identified and acted on. Are there any questions or comments about the action log? No? Great. Thank you very much, colleagues. We're now going to move on to the patient story, and I'm really pleased to have Abby Lee with us today. Well, I can't even speak. Abby Lee with us today, who is a volunteer and service user, and she's going to share with us some of her story. But also we have Emily McGowan, I hope I pronounced that right, who is a clinical psychologist and supporting clinician who's with her today as well. Really glad to have you with us and really interested to hear what you have to say. Over to you.
Hi, so as Caroline just said, I'm happy. I'm a woman. Hi, can everyone hear?
Can we
Everyone
turn,
hear?
can we turn the volume up a little bit? Brilliant.
Our computer doesn't work very well, so can you hear us better now?
That is a lot better.
Okay. Right, so today I'm going to talk about my volunteering experience with a bit of background into my life, background in mental health services, and the things I've overcome, which have led me to where I am today. So my volunteering story is probably very similar to others in some ways and completely different in others. My decision to volunteer was based on a number of things. Firstly, I wanted to gain experience to help me progress towards completing my degree and future career aspirations. I wanted to learn and develop new skills, but most importantly, I wanted to help others in any way I can, as I know from my own experiences how much people benefit from these services within the NHS. Gain a bit of an understanding of my reasons for volunteering, including signing up to my degree in the first place. I feel that it's important to provide a bit of information on my background and what led up to this decision. So I struggled with my mental health for many years. I was enrolled in CAMS for a while in school, and then around the age of 18-19 I got referred to a CMHT, which I was discharged from only at the end of last year. So throughout this time I spent much of my time in general and psychiatric hospitals, including Westlands, where I am now.
Is there any chance we can turn it up a little bit more or come a little bit closer, because it's quite hard to hear you and we don't want to miss anything?
I'll put headphones on so she can have a microphone.
You're very actually that was perfect sound there.
Well,
from
I'm
you,
on this
Emily.
end and I'm
Pardon?
very loud. So. There you go. Shove that on you. And then
Come a bit closer, Emily.
There you go. Is that any better?
Brilliant.
Loud.
Excellent.
Perfect. Do you want me to start again or?
If you want to say, yeah, if you maybe want to just capture a bit of what you were saying, I think I could hear. I don't think others could. So yeah.
Okay, I'll start again.
Whatever you feel comfortable with.
That's fine. I'll start from the beginning. So today I'm going to be talking about my volunteering experience with a bit of background into my life, background in mental health services, and the things I have overcome which have led me to where I am today. My volunteering story is probably very similar to others in some ways and completely different in other ways. My decision to volunteer was based on a number of things. Firstly, I wanted to gain experience to help me progress towards completing my degree and future career aspirations. I wanted to learn and develop new skills, but most importantly, I wanted to help others in any way I can, as I know from my own experiences how much people can benefit from these services within the NHS. To gain a bit of an understanding of my reasons for volunteering, including signing up to my degree in the first place, I feel that it's important to provide a bit of information on my background and what led up to this decision. So I've struggled with my mental health for many years. I was enrolled with CAMS for a while in school, and then around the age of 18-19 I got referred to a CMHT, which I was discharged from last year. Throughout this time I'd spent much of my time in general and psychiatric hospitals, including Westlands where I am now, and thought my life was going to be like that forever. After a while I realised the detrimental effect my job was having on my mental health, and therefore quit my job. I left my career as a chef behind me with no idea what to do next, but knowing that whatever I did, I wanted to help people. A few months later, I signed up for a psychology degree at the Open University with the hope of working in mental health services and helping people like myself. But as anyone with mental health issues knows, recovery isn't linear, and there will always be more battles to face. Not long after I started my degree in 2019, I found myself living in a homeless hostel and becoming reliant on drugs to control my emotions, having a further impact on my mental well-being, as well as my ability to complete both therapy and my studies effectively. Around 8 months later, just before starting my second year of university, I had to move to a refuge due to abuse from my partner, who also lived in the hostel, leaving all of my friends, family and mental health support behind. This was an awful period in my life, but I knew that I could get through it, and despite the distance from home, I wasn't alone, and not long after I made some lifelong friends. I moved back to Hull in January 2021, And after settling in for a few months, I decided that was wrong. I moved last year, sorry. And after settling in for a few months, I decided that I would apply to start volunteering. I felt that sorry. I felt that I could use my experiences of mental health, homelessness, abuse, drugs, and struggles to help and inspire others and show them that things can and will get better. I also really struggle with my confidence and therefore try to avoid situations that are anxiety provoking as much as possible, and therefore thought volunteering may be good to help me build that confidence up. I also wanted to try. Sorry, I've got something on my voice. I also wanted to try and gain some experience alongside completing my degree due to having an aspiration and passion to work in mental health settings and work alongside staff and patients to make a difference, even if it's a small one. My time living in hospitals and a refuge alongside my mental health also meant that I had not worked for a few years, and therefore thought voluntary work would help me get back into my working life. I also hoped that it would help me with the last bit of my own recovery, giving me a purpose, a routine, structure, and value, all of which I lacked beforehand. I started off my voluntary work at the COVID-19 vaccine site, hoping the site runs smoothly. And not long after, I picked up telephone befriending, calling service users during the pandemic and showing they had someone to talk to. My telephone befriender constantly tells me how much she appreciates me calling and how much it helps, and therefore I still keep in contact with her weekly, even though the service has ended. I then went on to do some voluntary work with the Recovery College, helping to create a podcast around mental health and recovery, which is then released on their platform. This role has got me involved with the planning, recording, presenting, and occasional editing and organisation of guests coming on at times. The connections I've made through these roles will last a lifetime, and I like to think the positive impacts of the work will last even longer. I then started at Westlands in September, helping with activities on the ward once a week alongside the activity coordinator, interacting with patients and encouraging positive well-being. A few months later, the activity coordinator moved to a different ward. However, Westlands had just hired a clinical psychologist, M, and somehow managed to convince her to take me on as a volunteer, which she probably regretted at some times. When I started at Westlands, I had no confidence whatsoever. I didn't want to speak or share my opinion in case I said the wrong thing, sounded dumb or stupid, and I never believed anything I said was worthwhile hearing. The thought of doing skills and narrative groups on the ward is something that I tried to avoid multiple times, always saying no when asked me if I wanted to take the lead that week because I was too scared of messing up. At this point, I doubted my abilities, my degree, and my career because I never thought I would be able to have that confidence, which is vital to any psychology role. However, even though my anxiety still gets in the way and I experience it daily, I managed to overcome this and I'm now able to lead groups on the ward regularly, which even in January I never thought would happen. The amount my confidence has grown from volunteering, especially at Westlands, is unbelievable, and I'm really thankful for Em for helping me build that up. I also helped create some of the patient leaflets for the group so that they have something to take away with them. So far, while volunteering at Westlands alongside Em, I've sat in on assessments, reviews, MDT, discharge meetings, etc., enabling me to gain first-hand knowledge of how these work and sessions run. This was a massive change of perspective from what I had previously seen as a patient, and I believe enables me to be able to look at things from both the patient's and staff's point of view. Alongside this, I've also helped with a file review, learning a new skill that will likely come in handy, and still occasionally help out with it. And I still occasionally help out with activities on the ward, ensuring that I interact with patients. My volunteering journey has not been easy from the start, with many challenges, including loss and illness, causing me the need to take a short break, alongside the issues and pressure of trying to finish my degree while having my laptop and computer break and moving house with about a week and a half before my final deadline. I had times where I doubted everything I was doing, when I wanted to give up and thought my aspirations were out of reach. However, through volunteering, I've grown so much as a person in various aspects of my life. And I am... sorry, one second. And I am forever grateful for the opportunities and support I have been given from all my voluntary roles, the voluntary services, and especially in this time. And for a long time, And for the first time in a long time, I'm happy and enjoy what I'm doing, which is all I ever wanted from the start. I'm really excited to see what these next couple of months bring before I go on to complete my master's degree and find paid work. But I truly believe that my volunteering experience through the trust has prepared me for these next steps. I didn't write this down, but just to add a bit of extra on as well. So one thing I would like to say as well is that when I started volunteering here, I very much felt like I was kind of like an outsider, because I'm not employed here, I don't work here, and I was just sat there like, well, no one's really going to want to get to know me, no one's really going to be interested. And that's something that massively scared me as well. But during that time, made friends on the ward, get along with everyone. I would like to think I've made some friends here, and that I'm kind of like made to feel like part of the team, which is amazing. And I'm really hoping that lasts after that, and if not, me and them went to go buy a budgie. So it's a everlasting thing from Westlands that I now have a budgie in my house because of that, which is just an added bonus. Yeah. But yeah, I'm really grateful for absolutely all the opportunities I've been given, and I think it's helped me massively. And I'd like to think that I've made a difference to patients and staff here as well.
Thanks so much, Abby Lee. It's lovely to see you again. And I really enjoyed my visit to Westlands and was glad to have a chat with you there. And I think you were leading an activity during my visit, I recall. So I'm really thanks so much for coming along today and sharing the story. And obviously when I went to Westlands, is there as well as the clinical psychologist, and I think that's really benefited the team working at Westlands as well, from what I heard from others on my visit. So thank you so much. Thank you for sharing that. It's great to see how the volunteering has helped you in so many different ways. And good luck with the masters. When do you get the result?
So I get my results for my undergrad on Tuesday, but I should get them Monday, and then I start my master's degree.
Brilliant. And before I hand you over to other people, what's the name of the budgie?
Sully.
Pardon?
Sully from Monsters Inc. And then we're going to get him a little friend called Mike, so it's Mike and Sully.
Okay, thanks very much. And right, this is your opportunity to ask questions or make some comments. So over to the Council of Governors. Hanif.
Thank you, Chair. Lovely to meet you, Emily, and really great to hear that story. I'm one of the Associate Non-Exec Directors, and I'm helping one of our colleagues, Bethia, who runs the Humber Youth Group, just to get that moving even better than it's already going. I'd be really interested in hearing from you in terms of what we might be able to do better that would not only get young people on board to volunteer like you do, but keep them there, because obviously as young people you have lots of different interests, and it's easy, to go and do something different. So it was great to hear that you've been involved as long as you have. But have you got any tips for me and for us that we could go away and use, as I said, to make sure that we're doing the best job we possibly can with young people and volunteering opportunities?
Thanks, Hanif.
I think with a lot of people, and I've had a lot of friends mention this as well, is that they're not actually sure what voluntary work is, what they can get involved in, and what they can do. And I have had a lot of people who's come up to me and say, oh, well, what do you do? Because I want to start volunteering, but I want to do something that I enjoy. And I think the other bit is finding something that you do enjoy, having a member of staff like who is just really, really supportive. Yeah. But I think that makes a massive impact as well. So it's more about getting out there, what you can do, and find someone. Obviously, volunteering was
Great, thank you.
Before I bring in Dov, can you just put it, whatever you did at the other end to make the sound better, could you just do it again, because the sound level's gone down again?
It's the headset. I can try and speak a bit louder. I had the headset on before, which means
like this laptop just isn't good. So like if the mic is over here, it's because then you can hear me better. But
I'll try be a bit louder.
Yeah, that's better. That's better. That's better. That's good. Doff.
I'm Dr. Morad, and I'm the governor for Whitby. and I found what you had to say really, really interesting. And I think it's great that you put yourself in the position to expose yourself to talk to us, and I think that's great. So well done, and I'm really, really excited to hear your story. It was really good. What do you think was the most important thing that people within Humber did to help you on your way?
I think a lot of it's just do with the support, making sure you've got the support with you, because I think that's the one thing that makes probably the most impact over anything else.
Okay, thank you very much.
Thanks, Doff. Dean?
Thanks, Abby. That was a great presentation, and really good to hear about that whole experience, as it were. I just got one question, which is I'm just interested in what you're doing your master's degree in, and then secondly was just the other interesting thing that came out to me is that although many people will do volunteering to learn some skills, you know, how to work with service users or patients or in a ward environment, I think what you emphasised there was those learning of those soft skills, making friends, working as part of a team, feeling a bit more confident, and it's great to see that expressed in the way that you presented today. So that's brilliant to see. Thank you.
Thanks, Dean.
Can I add as well, if people can still hear me? Yeah, I think it was about, it's been a huge thing about knowing where your boundaries sit as well. So like when you go into psychology, there's some things you'll know that you can tolerate and some things you can't. And throughout your entire like experiences, it's been getting to know that as a person. And then as you're trying going into the psychology career, it's knowing that. So to prepare you for the career going forward, we've had discussions about that and that reflective thinking. So there was one person who I suggested an assessment for that we realised wasn't appropriate for you to sit in on from a personal perspective. So that was an incredibly useful conversation that got you reflecting on, you know, loads of different things and what was best for you. And it's been that kind of transparency and like mutual understanding that's created such a strong thing. And like we just get associated with this as psychology now. You know, people just turn up, you know, we just turn up together and all this stuff, and it's just become rooted in the team because Abby's here so often, and usually we're, you know, contributing so much more to handovers and meetings, and because of our own personal experiences, it's been so helpful for me and the team to understand like the context of what is available, the quality of it, or at least her subjective experience of it. So it's been absolutely invaluable.
Thanks. That's really helpful too, to have that contribution. Abby, your Dean was asking about your masters there.
Yeah, I was just about to say that. So I am going to go do cognition and neuroscience at Huddersfield University. And then hopefully in a few years I plan to go do my doctorate.
Brilliant. Jenny Bristow.
Hi, thank you, Abby Lee. Thank you very much. I'm sorry you can't see me. I'm also having laptop issues. Mine is that my camera doesn't work, but hopefully you can hear me okay at any rate. Emily, I think, answered some of my question that I had, but it was around your experience in terms of being able to voice kind of the good, the bad, the ugly from what you're seeing as a previous service user, but then coming in not there every day, but just seeing it from kind of an outsider's view. And then the other thing that I just wanted to mention to you is that obviously I'm a governor, but I'm also a police officer, and I just wanted to say thank you for sharing your story and how you've changed your life around, and what you've done in relation to that. It is absolutely fantastic for me in my other role, my day job, to hear that and see that, you know, anything is possible, and well done and good luck for Tuesday.
Thank you.
Did you want to come back on something that Jenny was asking about, seeing it from the outside and then coming in, about you, how it shaped your views?
I don't know. I think a lot of it's because I used to be a patient here. I know exactly. I mean, I know how the patients are feeling. I kind of know what they're going through. Quite a lot of them have like similar or like same diagnoses as me as well. So it's kind of the thing of I can understand how they're feeling. I can understand the impact that staff decisions will make on them. and vice versa, if that makes sense. So I think I can't really think of an example.
Well, you've getting to know the theory, and you're also an expert by experience, so it's like double whammy, isn't it?
Yeah, and then the other thing is that I can relate to patients a lot more as well. So there's like patients that we get on the ward that I've known from when I was in services, and it's also kind of that thing of they know that, and they kind of see it as, well, okay, she's got better, I can get better type thing. I kind of
you're an inspiration to the people in like a subtle way.
Subtle,
because you don't advertise it at all, but just being there and sharing things.
And I mean, it's quite obvious that I struggled with mental health issues into the patients because I've got scars and stuff on my arms, and I think that actually also makes a difference as well, because it's also the thing of knowing that the people who are helping you do actually understand what they're going through.
Thanks, Abby Lee. I've got Stuart, and then I think I've got Michelle.
So, hi, Abby Lee, Emily, I'm Stuart McKinnon-Evans. I'm going to give you a bit of feedback, Abby Lee. You described yourself, I think just a few months ago when you wouldn't say boo to a goose, you didn't want to lead any work. And now here you are presenting to a group of people in a very confident, compelling, calm way. And I'm with my team today, my main office. I work with about 100 people. Many of them would not be able to do what you're doing. So your transformation is quite amazing. Well done. And my question to you is, was there a point when you suddenly felt like a different person? What was there a sort of a moment when you thought, right, now I've cracked it?
I don't think there was kind of like a point. I think it was just more an ongoing thing. And it just, I kind of just see myself like kind of get better and improve as I go along. So yeah, it's nothing I can really pinpoint. It's just like bit by bit progress that kind of got me to where.
Well, however you did it, fantastic. Well done. Thank you.
Thanks, Stuart. And finally, Michelle.
Good afternoon, Abby, and thanks very much. I'm sure I'm executive, and Stuart actually said what I was going to say about, because you said something, you were saying, oh, I'm not used to this and what have you, and it's just an amazing presentation in front of a group of people on Teams, that some of which you've seen, some of which you haven't seen, but also to the public, and it was so well put, well directed. So, really, really interesting. So thank you for that. I just wanted to say, obviously, good luck for the Masters, but also let's keep in touch as well if we can, because I think it is inspirational, and I think we need to utilise your experience, not just for service users and patients, but for staff as well. Because I think, as you said, sometimes you felt that staff wouldn't know what volunteers were or how. But now you're part of the team, and I think sometimes we do tend to get a little bit of that. So I think it's about how we can integrate volunteers, your experiences a lot more on the ward, and I think if we can somehow keep that work going, or at least make sure that we've got, you mentioned a podcast on, that we've got it so that we can utilise it. I think that's so important for future as well. But absolutely fantastic. You really made the meeting stand well. I made my Thursday afternoon, so thank you so much. And best of what you do, and thanks to the team as well at Westlands and everywhere else. And what a vital service with the vaccination centre, because I worked there as well, and it wasn't an easy job to do either. And the volunteers were key as well. Yeah, out in all weathers as well. So thank you so much. Fantastic.
Brilliant. Is there anything else you'd like to just add, Abby, or Emily, for that matter, before we finish this part of the agenda?
I've enjoyed the journey, to be honest. As you were saying, Stuart, about that, if there was a pinpoint, it has been more of an evolution of, I think the biggest thing for me is witnessing the confidence in delivering groups, for example, because at the beginning you weren't even confident to say no. It was just like a lack of answer. Whereas now it's kind of like, I can just leave you to it if I need to go into a different meeting or a discharge meeting or whatever. And it's so nice because I know that you will tell me if something's up and that kind of thing. So it has just become something really valuable to everybody, I think.
Brilliant. Thank you so much, Abby Lee. Thank you so much, Emily. Great to see you. Let us know how it all goes on Tuesday, and look forward to seeing, no doubt, again. Have a fantastic rest of the week. Thanks so much.
Thank you.
Bye.
Bye.
Great. Lovely, that's great. I mean, for the new governors, you know, both at Council of Governors and the board, we always have as a standing item sort of hearing from patients or volunteers or staff about some of the work and volunteering and using of our services across the trust. And I think it just, you know, again, just gives another dimension to our knowledge and insights about what we do, how we do it, and how people feel it's working for them, whether they're a service user, volunteer or employee. But that was great. That was really great. It was lovely to see Abby Lee again. Patrick, welcome. Patrick Harvey is one of our governors, is with us.
I do apologise.
No, don't worry.
I've really had difficulties getting on this blasted thing.
Okay.
So, sorry.
Well, you're very welcome. You're very welcome. Great to see you. So we'll just move on then to my report. Just a few things that I wanted to flag up with you. Since the Council of Governors last met, Sue Cooper and I have been involved in doing all the appraisals of all the non-executive directors, and also Francis Patton, the Senior Independent Director, and myself did the appraisal of Michelle Moran, the Chief Executive. On the Governor's side of things, we've got this on the agenda later, the working group was set up, a small working group to look at support for governors and development, and the report of that is on the agenda today. Thank you to those who took part in that. We've also had 2 Governor Development Days since we last met, and they seem to have gone very well. In fact, the last one was a new sort of version of what we are going to do in the future, which incorporates our NED chairs being able to do an informal Q&A session on their work. And there's more of that on the agenda later on today. But we also, at those 2 Governor Development Days in particular, first one, we had a focus on how the trust assesses risk, and we had Oliver Sims come along to that, and that was a really helpful opening discussion about that area of work, I think, and it raised a lot of questions, but I think it was a useful session to have, and governors had asked for it. And we also had, at the last Governor Development Day, Dr. Iqbal Hussain come along and do a presentation and discuss with all of us our primary care services across the trust as well, particularly in relation to GP practices, and that was well received. And we also discussed health inequalities across the area that the trust has services in. So that was really helpful. We've also just this week had an induction for our new governors, and I hope they found that helpful too. And just to flag that the visit programme for NEDs and governors is being pulled together, and I'm meeting with Jenny and Katie and Kerry and Libby from our board support unit next week to try and finalise and put together the programme going forward for NEDs and governors to undertake visits, knowledge visits later. So there'll be more about that coming to you shortly. As you heard in the last private meeting of the governors, we ratified the appointment of Dr. Philip Earnshaw as a new non-executive director, and he will be starting on the 25th of July. We've also, and Michelle may say something about this as well, since the Council of Governors last met, there's been a recruitment process for a new medical director and director of corporate affairs. John Byrne has left us as an organisation, and we wish him well in his new role in London, in one of the ICSs there. And Michelle Hughes, who is the Director of Corporate Affairs, is also going to be leaving us, not straight away. We're not letting her go that lightly, but again, we've completed a recruitment process for her post too. So quite a few changes. Visits, you heard that I went to Westlands. I've also been to Town and Court. Michelle Moran and I were up in Scarborough pretty much all day this week. I think, was it Wednesday? Was it Tuesday? It was Wednesday, was it? Tuesday, Wednesday. Tuesday, it was Tuesday, and we met with some of our district nurses and specialist nurses who provide the community, form the community team there. We also had a meeting with some residents from Market Wheaton about the GP services in their neighbourhood, and there's going to be another meeting, I think, scheduled for September. So that's just a few headlines from my activities since we last met. Are there any questions at all? No. Okay, thank you very much. We'll go on then to the Chief Exec's report. Michelle.
Thanks, Shed. Good afternoon, everybody. Nice to welcome our new governors. We're here for any help and advice that you need, but welcome to the team. Hopefully people have had a chance to have a look at my report. I won't go through it in detail. I'll just pick out some headlines, just building on obviously what Caroline said. Yeah, the recruitment process post went well. It's been a really stable team. About 4.5 years since we've done any recruitment, so it's really an interesting process, but I'm very pleased to say that we have made more on that later when we've been through the process. Thank you to everybody who helped and supported my challenge. I do an chief executive challenge every year, around about the longest day, and this year was an 85-mile bike ride, and that because it was covering the whole of our patch. We set off from Inpatient and ended up at Whitby. Those of you in the room know me will be pleased to know it wasn't actually on the road. It was on a static bike, because I would be more at risk to everybody else if I was actually on the road. So it was static. It was great because staff and some service users joined us as well for part of the stage. The chair joined me for part of the stage. But what is more important is we raised over £6,000 for that, and that included, that wasn't in addition to that, we obviously hired the bikes and everything else was extra. So it probably was a bit more than that. But that goes into Health Stars, our charity fund, partly for patients, but also partly for the staff health and wellbeing fund. And I'm just working through what I will be doing next year. But thank you to everybody that contributed for that. Really pleased to know that we're now known as a formal menopause-friendly employer. We've done a lot of work over the last 6-7 months, particularly on menopause. We were doing quite a bit of work before then, but we've really delivered our service in relationship to menopause, and I thank everybody from HR that's made that possible. But that's really, really important, and we'll continue that work alongside other colleagues within the community care system as well, who are also now doing that work. There's lots of awards in there. I won't go through them, but we've been shortlisted for several awards and won several awards as well, which is great. And that's really, really positive for the staff, because it's a real tribute to how fantastically our staff are working in what is really challenging conditions. And I'll come on to that shortly. We have got some internal place leads that link into the integrated care system, but I'll come on to where we're up to in the wider integrated care system in a second. There's a section on the Mental Health Act proposals that's there to read. We'll obviously do more briefings as we deliver that, and I'm sure Mike Smith will do some more work on that as we progress the changes to the Mental Health Act, and Mike's nodding. And I thank Mike specifically for his work and support that he's giving to the executive team and the Mental Health Legislation Committee, alongside obviously our associate managers as well. We were pleased to welcome our 0 to 19 staff for the 0 to 19 service in Hull, and they're starting to really work closely with our East Riding 0 to 19 service as well. And we're interested in that in relation to the integration of those two services to reduce variation across the patch, and that's visiting, school nursing, etc. And being a health visitor by background, it is really important, and we're really starting to do some positive work in Hull. There's a little bit about the prison service. The prison service in Hull came up for tender. We're trying to reduce the number of tenders that we do in the system as we develop our collaborative approach for providing collaboratives. But prison service was one of those that was sort of the last ones. We don't provide prison service. Really our forte, and we've always made a point of being really clear in relationship to our strategic direction and our strategic intent for responding to tenders. So we did a bid and a joint bid with Cheese Esquimalt Valley, and that was successful. So we're providing the community element of the prison service, which really links into our community forensic service. So, but it's a really important partnership as well. So we're really pleased with that. There's quite a lot on zero events, which I'll let you read, and I think we've had conversations at governors' meetings about those before. And there's our usual comms report. Our comms team are very active, both internally communicating with our staff and our colleagues internally, but also externally as well. So I thank the staff, and it's been a very busy month. Lots of awareness days, but lots of other aspects in relationship to comms as well. And there's an update from our charity Health Stars. A couple of things I'll touch on. The integrated care system is now in official. It got statutory organisational status on the 1st of July. So it had its first public board meeting on the 1st of July, and it had a second meeting yesterday. I'm a member of that board. The provider sector, and as people know in the audience, I also develop in the provider collaborative alongside other work around innovation. But it's really good that that's now a statutory organisation, because we can move forward with the transition. But what's interesting, and apologies to board colleagues, I've not been through all this with the board yet, but I will do, is that most of the place leads have been identified. If you remember, we've got 6 places in the integrated care system supporting integrated care. I'll just quickly whiz through these, and then I will leave the integrated care system. There is a webinar, which I'm more than happy if governors want to come to. We can send you a link. I think it's around about the 21st of July. Don't quote me on that, but it's sometime soon, when I'm just doing an hour in relationship to where we're up to in the integrated care system. So North Lincolnshire, the place lead, each of a place lead, which is an NHS representation, and the place chair that usually comes from the local authority. So North East Links, it's Helen Kenyon that's the place lead, and Rob Walsh is the place chair. In York, that's the one post that hasn't got a place lead, but the chief executive, or the chair lead from the local authority point of view, is Ian Floyd. North Yorkshire and York, it's Wendy Balmain, who is the place lead, and Richard Flinton, who is the place chief exec chair. North Links, it's Alex Sale, supported by Peter Thorpe. Alex is the NHS, Peter Thorpe is the local authority. East Riding is Simon Cox, again supporting that NHS place lead, and Caroline Lacey, the chief exec chair of place. So they're really starting to develop now. So we'll keep the governors involved, and it might be something useful, Chair, that we want to do as a development session later on. I'll pause there for a second, but I will come on to COVID and winter pressures and where we're up to in relation to challenges. There is a report in the paper, but I usually just do a bit of a stock take verbally. We're still under enormous pressure in all the services across our organisation. The demand hasn't really subsided specifically. There's been a few little dips, but not significantly, which we would expect to see this time of year as people get into the holiday season. And certainly from adult people, we do have a little bit of a decline going into the summer. We have usually quite a large intake in September when the schools go back. At the moment, we're still having not a decline in the service, and against the trajectories that we've done as well. And we anticipate that will continue. We're also continuing to see quite high acuity of our services, and we're looking to see how that is being affected by, say, primary, etc., and earlier access, not to our services in the main. That is compounded by, but actually we have got some really positive news stories. Our out-of-area placements have dramatically decreased over the last time since I spoke to the council, which is really positive news. These are people that are placed out of our area. Usually it have been over the last couple of years because of the reduction in beds because of COVID. But that's dramatically reduced, which is really positive. COVID, our incident of COVID is increasing. We've got 10 patients today with COVID, which is the highest it's been for a long, long time. And we've got a raise in staff sick in relationship to COVID, which has significantly increased over the last week. So we are re-evaluating our infection prevention control. As you know, we've been quite ahead of the curve for a lot of it. You're still using the risk-based assessment with each of the areas doing risk assessments based on the ventilation, numbers, staffing, etc. Most of our clinical areas now have gone back into wearing masks and social distancing, and we'll continue to review it on a daily basis. It is hotting up out there, pardon the expression, I don't mean the weather. We have started our winter planning, and we're doing a lot of different work in relationship to winter planning, but also working with our partners as we did last year for that system effect. And we're also starting to plan for our flu vaccination season and our COVID vaccination season. And if we're looking at Australia, which we always do, they're obviously having quite a lot of flu as well. So we really will need to do a lot of the publicity in relationship to the flu vaccine, as we usually do, rather than just the COVID. Lots happening, Chair. I will pause there. I know that there's a couple of hands going to up, I think, maybe not. But I'll leave it there now and open it up to questions. Thank you.
Apologies. Thanks very much, Michelle. Is anybody like to ask a question or a comment? Will, you had your hand up earlier. Did you still want to ask something?
I was just the sound quality really broke up there.
Yeah. I don't know whether it's at your end, Michelle. It was cutting out a little bit during your contribution. I'm not sure we could do anything about that.
If you disable the camera, then the bandwidth tends to go to the audio and it tends to be clearer.
It did. I didn't realise it was an audio problem. Sorry. Didn't people get the gist I was saying?
Yeah. Okay.
I'm getting some, yeah. Anything that needs clarifying by anybody?
Okay.
Happy to go over it.
Any questions about anything that's in the report or anything they picked up on what Michelle has said? Doff.
I found it really, really useful and helpful, and I'm very interested in what you had to say about place, and I've put a note in the chat box. I feel that the role that the governors have in supporting the integrated board is one where we need to ensure that we have as much understanding about how we're working together, and place seems to be the best opportunity for us as governors to really get a feel for how the integrated work is going on. So I'm really excited about how we can find out more about that, and how governors, particularly governors who already take part in the patient care experience work. I think we've got a march on perhaps some of the other people, because I think that Humber has really developed that work, and I think it's a really good platform to move that forward. So more of a comment than a question.
No, I think you're absolutely right, Doff. I know that we've spent a lot of time talking about membership and how governors engage with their constitution, their membership, and I think you're absolutely right. Doing it through place is a really good way of doing it. So we need to make sure that we feed that into the integrated care partnership work, but also I need to make sure I feed it into the board as well, and we also do from an organisational point of view. That is one of the reasons, I'm hoping my mic is still all right, one of the reasons that I included partnership working in the new corporate affairs post. It's not in Michelle uses at the moment, but it is actually in the new job description, and that was one of the reasons, Doff, which is to really have that connectivity between the governors and place.
Thanks very much, Michelle. There aren't any other hands up, so I think we can move on. Can we just put an action, I think, to send out details about the webinar to governors, but also, if it's possible, if the board support unit can pull together the names you cited there, Michelle, in terms of the leads at place, to maybe circulate it. Some of this information will become fuller as time goes on, but I think if we can give you information that's relevant and helpful as and when, that would be good for everybody, and probably for the NEDs as well to receive that. I would have thought too would be good. They're nodding, so that's good. Brilliant. Thanks very much, Michelle. Now we're moving on to chairs of the Trust Boards Committee subcommittees report. Now, governors who've been involved in the working group and the development proposals, one of the asks was opportunities, formally and informally, to hear more from the NEDs who chair some of the subcommittees of the Trust Board. So today we've got this on the agenda. It will be a standing item on the agenda. In future, we're working at the moment, sort of doing a sort of template for the sort of report, a written report. So you've got something, if you like, to hold that we can use going forward. But for today, as the first one, I'm just going to ask each of my colleagues to really give some headlines from the committees that they chair, and then we'll open it up for comments or questions. So let's start with Stuart. Some of you have already met Stuart, but Stuart chairs the Audit Committee, the Collaborative Committee and the Charitable Funds Committee. You're all going to be quite succinct today, aren't you, to allow for questions, just headlines? Yeah, they're nodding. Fantastic. Over to you, Stuart.
Thanks very much and good afternoon, everyone. And apologies for those of you at the recent Governor development session where you'll have heard me say some of these things about those three committees, and I will keep it really brief. So let's start with the Audit Committee. my headline message to you is that the trust is in good shape from an audit and controls perspective, and I make that conclusion quite confidently on the back of the work of the internal and the external auditors and the specialist NHS counter fraud team who are assigned to us, as well as the information that comes to the audit committee from the executive and the management teams about performance and risk management, and how can we be confident that we know what we need to know, as it were. The last audit committee we had was on June the 21st, and that really focused on the end of year reporting, which will culminate eventually in the publication of the trust's annual report and accounts. And we kind of got good endorsement all round. So all positive reports from the internal and the external auditors, no qualifications. The annual governance statement was endorsed. The internal auditor, in fact, gave us a very, very good mark. This is a significant assurance that you don't always get that in an organisation about the trust control framework. All the programmes that had been put in place for the year had been completed. There were no changes to the audit plans, and on the whole, it was a very, very strong endorsement of the way that the trust is operating. So that's really good sources of confidence and assurance for us as the board members, and as for you as our governors. So that's good. The financial statements will eventually show, when they're published, a good financial performance. They'll be reported in full in due course. So all good on the audit front. Caroline, shall I proceed with the other two committees? And yeah, so the next one I look after is the Collaborative Commissioning Committee, and that has been established to provide oversight of the arrangements that have been put in place to provide through a collaborative arrangement. So a number of organisations coming together from the NHS, the independent and the third sectors to supply specialist services in relation to the following three provisions: child and adolescent mental health, inpatient provision, adult low and medium secure provision, and adult eating disorder inpatient provision. So some specialist services. The trust are a lead provider, and this committee set up to provide a kind of an arm's length independent assurance about whether the whole collaborative, including the provision by ourselves, if you like, is going well. And I'll talk about maybe three things that we've had our eye on. First thing to say is that this committee, the arrangements have been in place for nearly 2 years now, but the working arrangements are still to some extent bedding in. They're relatively new for some people, still bedding in, but the arrangements were well endorsed by the recent well-led review, and are very much in keeping with the spirit of collaboration that's emerging from the ICS system. So we're a trailblazer to a large extent in that regard. Secondly, our focus has been on one element of the supply, the Shurn Clinic, one of the providers in the collaborative, and they are taking urgent action in response to a reasonably critical CQC report. And so we're watching them very carefully. It's quite an early case study in how we can respond to an issue on our patch. And then the third thing I'll say is that the practitioners, the teams who are working in this collaborative arrangement, are generally reporting that the model is working well. So it's adding value more than the previous arrangements, which I think is encouraging and still developing. So that's a very quick headline summary of the collaborative committee. And then the final committee looks after the charitable funds activity. You'll have seen some in Michelle's report there, Chief Exec's report, some examples of some really outstanding individual initiatives going on, including indeed Michelle's own forceful pedal power. But against that backdrop, fair to say that the charity itself has had a little bit of a difficult time raising funds in the last year. So we're now working with them to redo a couple of things, reinvigorate the fundraising, including looking at all the different channels by which funds could be raised, and then working with the executive to help identify maybe a clearer statement of the need for funds with some standout campaigns to really chase down. So there we are. That's the work of the three committees that I look after. Thank you.
Thanks very much, Stuart. Do colleagues want to ask questions or hear from the other chairs of the committees? Okay, so let's go and hear from the other chairs and then we'll come back. So I'll go to Mike next, who chairs both the mental health legislation and the quality committee. Mike.
Thank you, Chair. I'll start off with the quality committee because that's foremost in my mind at the moment. The last meeting was in May, so those who were in the government development session may have heard some of this. So I'm going to try and make it a bit different today. So in the May meeting, we considered the patient safety strategy refresh. We approved the draft quality account subject to the latest information being put in. We looked through the medicines management work with pharmacy technicians and some innovative work there, which was a result of a community mental health survey. We looked at patient safety training and particularly the white ribbon champions and ambassadors, and there's a white ribbon action plan. And we looked at the R&D work. There was an action in there though. There was an action from the well-led review, which was for the chair to attend the quality and patient safety group. And it said this has been booked for July 2022. That was yesterday. So I can give you an update on the quality patient safety group. This sits beneath the quality committee and does what one of my ex-colleagues would have said was the heavy lifting. So it processes the policies and procedures and gets them to a form where they can come to the quality committee for approval or otherwise. 555 pages and a 2-hour meeting. It's chaired by our Director of Nursing, who did an absolutely superb job. It was totally clear that not only Hilary, but also the people attending in the meeting were on top of their papers because we were able to go straight to them and they highlighted the salient points. We've got track changes on the policies. So even though it was a long agenda, we got through it pretty quickly. Stuart said the trust was in good shape financially. I heard that the trust was in good shape from a quality point of view. We had the quality dashboard, which was very positive. That covers things like friends and families tests, complaints, compliments, incidents. There are a large number of incidents at the moment, relatively, because we have a very complex patient group. We looked at the safeguarding annual report. We noticed the common issues that are there throughout the country. Domestic abuse, and child neglect are the two big ones. It's part of a place-wide approach, but we did consider it. We also considered the groups that sit underneath QPAS, and it does sound a bit bureaucratic, but there are so many levels in this organisation of things that need to take place that we heard that there was an audit and effectiveness group, which investigates any activities, so that's a sort of deep dive group. There's a clinical risk management group and there's a clinical governance group for each division. And these are really, really important because Doff challenged me at the Governor Development about how things are communicated in terms of risk. And I did follow it up, Doff. And I can tell you that all incidents entered on Datex are reviewed daily by the corporate safety huddle in the division. Further information can be requested from the reporter, but the staff member will get feedback because whatever's discussed at the safety huddle will also go on Datex, so they could go back to Datex and see what happened. In addition to that, the teams are encouraged to interrogate Datex to look for any themes that might apply to their department. Just finishing off, we had a presentation on community services. One community. We have a member of staff called Kerry Brown, who's been with us for a couple of years. And in the last 2 years, she's been integrating services, developing staff, mixing skills, and setting up virtual wards. Tremendous work taking place there. And then for the finale, we received the training report. We have over 100 students across the 3 years of the nursing programme, and they're all doing really, really well. The big issue is placements, but more staff are coming in to support with placements, and there are even placements taking place, including admin. So it was a really, really positive meeting, and I finished off at the end to say the 3 words that they all wanted to hear, which was, I am assured. So I was assured that QPAS is working really well and effectively. So that's it from quality. May I move on now to mental health legislation, which is my specialist subject. Caroline?
Off you go, Mike.
Yeah.
Start at 10.
Mental Health Legislation Committee, I did report back to the forum. I considered in particular the Mental Health Units (brackets Use of Force) close brackets Act 2018, which came into force this year. And I was at great pains within the development session to say that this is news. There are new responsibilities, like a responsible person. There are new reports that we have to put in. However, it is news with an S. It is not new. It's what we do. And we are a positive outlier in terms of restrictive interventions. So this is in terms of seclusion, restraint and things like that. We do that much less than other trusts do. We benchmark really well. We approved the inpatient search policy, and as again I explained to the last meeting, this is to do with balancing human rights against safety. So we can't be intimately body searching everybody, but neither can we be so slack that people can come in with knives or drugs. And we also looked at the multi-agency public protection arrangements, which are really important for individuals in society who pose a danger to us and other people. And I was privileged to attend a couple of meetings and the foundation training for that. I don't know if Jenny Bristow will be involved intimately, I'm sure, but a really fantastic process where every element of a case is looked into, action plans are produced and action plans are implemented. But now to just vary the theme a little bit, latest news hot off the press, the mental health bill was published last week. It's a strange one in terms of what it has in it, which was expected, but also what it doesn't have in it. And there are 4 new guiding principles: ensuring service users' views and choices are respected, ensuring the mental health powers are used in the least restrictive option, and ensuring therapeutic benefit, and ensuring that patients are viewed and treated as individuals. What isn't in there is that the government consulted on improving the interface between the Mental Health Act and the Mental Capacity Act. That has not been considered at this moment in time. They also considered the removal of hospital managers panels. This is the panels that people like Tim Durkin and I occasionally sit on. That hasn't come through either. But what has come through is, like I say, the guiding principles, but also a proposal to lessen the periods of detention. So if you're detained under Section 3 of the Mental Health Act at the moment, unless you're discharged, that will last for 6 months. Then there'll be an automatic referral to tribunal. That's been proposed to go back down to 3 months. But all of these proposals are very, very significant, and they're significant in particular in terms of the tribunal service. And it's estimated that it could take 10 years to actually get to full speed with the demand that will be placed on the judiciary in terms of these changes. So at our August meeting, Mental Health Legislation Committee will be reviewing this and be coming to a view as to what we need to do about it. At the moment, it'll probably be a watching brief, but we will be monitoring it closely. So that's it from me.
Thanks very much, Mike. Let's move on then to Francis, who chairs the Finance and Investment Committee. Francis.
Thanks, Caroline. We've not had a meeting since April. We're actually due one next week, so my update's a bit outdated, although there's some up-to-date stuff as well. We tend to split our agenda into 3 elements. One is around insight about what's going on in the wider arena, then around the Trust's financial position, and then around business development. In terms of insight, we review the NHS position financially, which when we looked at it in April was on budget, and the ICS performance, which again was on budget. And in April, we also looked at what was happening potentially with the pay awards that were coming for staff, which obviously we've still not heard anything about. As Stuart said, very strong financial position both last year and this year to date. So in April, we reviewed the year-end position, and it's the strongest financial position we've had in the last 5 years, and is a credit to the whole executive team and what they've been doing in developing our finances. We had delivered our plan and our ICS target, and we'd hit our business reduction strategy for the 5th year in a row, which again is a credit to the team. We looked at cash in detail. I know governors have talked about cash. We need cash for CapEx, When I joined the trust 4 and a bit years ago, our cash was quite low, and we need cash, as I said, for capex. Now that we're in a stronger position, we can spend more cash, and we have been spending stuff on staff, facilities, and improving things for staff over the year. We also reviewed the ongoing development of the plan for this year, and where that got to, and supported the execs approach at that time for a deficit plan. And we also reviewed the 3-year business reduction strategy plan going forward, and recommended bringing a case study from last year to board to show how innovative we are being in our approach to BRS. The other thing we looked at was the risk, because again, I know through Mike and through Duff, you've been asking about this. We reviewed the risk management annual report, which looks at detail about how we've managed risk over the year and all the various risks and the risk strategy going forward. Since then, obviously, the budget plan has been agreed, both internally and with the ICS, and it's a balanced plan. And 3 months in, we are delivering on that. Cash remains a focus very positively. We've got a large amount of cash, although that does include some provider collaborative monies. And we've now developing a cash flow forecast, which will come to FIC next week. And we're having a board timeout reviewing our cash position and where we need to be. We're having a focus on agency costs, as this continues to be an increasing cost, driven by our need for cover for consultants. And at FIC next week, we're reviewing the primary care performance and the primary care recovery plan. And then from a business development perspective, we also review the bids we've made for additional monies, and we've been pretty successful in getting some extra monies for primary care last time we met. And we also stress test some of the business plans, and so looked at some of the plans for the 0 to 19s that we've been successful with in East Riding and Hull. And we also look at what's going on in all of the various PCNs, so we get an update on that. So next week is our meeting, and as I said, the focus over and above the normal stuff is on agency cost and primary care.
Thanks very much, Francis. Dean.
Yeah, thanks, Caroline. I'm Dean Royals. I chair the Workforce Committee, and again, those in the development session will have heard some of the sort of background to that. We had our Workforce Committee yesterday, so some of this is hot off the press, and I thought that what I'd do is just let you know some of the sort of things we cover, and then just as we're going to do these more regularly, just explore a couple of concepts with you about some key issues about staff in post and things like that, so people have got a good understanding of the challenge around that. So the Workforce Committee gets reports from 3 subcommittees. So we have a staff health and wellbeing group, we have a quality, diversity and inclusion group, and there's an education committee that looks at those issues. Over the course of the last sort of 6 weeks or so, I've attended all of those as the chair of the Workforce Committee. We dip into those just to go and see what's going on and listen to the sorts of discussions taking place. But those minutes come up and we listen through those. We then have an insight report, which gives us loads of data around the workforce. So the staff, vacancies, sickness absence, number of training courses, amount of overtime, length of time to recruit, and a variety of other bit of data, turnover, etc., that we sort of have a look at and get some sort of more assurance and questions around those. And then generally what we do is we deep dive into some areas. So yesterday we did a couple of deep dives into leavers, so why people leaving, reasons for leaving, things that we can do around that, and sickness absence. And then we also looked at things like the hard to fill recruitment posts. We looked at a quality and diversity report that'll be going on to the quality committee when that next meet, because that looks at both staffing issues but also the people that we serve. We also had a look at things like a safer staffing report to see where we've got staff covering shifts. And then 2 other things that I just wanted to sort of go through with you, just in terms of the overall issue about staffing, and we also did the gender pay gap report. So I just want to cover those in a little bit of detail, because I think that those will come up and it's important for people to get the concept. So when we talk about the number of vacancies in the NHS and the number of vacancies going up, there's 2 things that we try and pay attention to. So for the trust, we've got the establishment, which is the number of posts that we've got funded, and then we've got the staff in post. Okay, so we've got an establishment that we're recruiting to, and then we've got the staff in post. And for us, about a year ago, that establishment was around 3,040, and the staff in post was about 2,670. So we have 12% vacancy rate. So budget versus the staff in post. Now, that doesn't mean that we don't do anything with that 12%. It's not that just people aren't there. That 12% is filled by people working overtime, part-time staff doing additional shifts, bank staff, agency staff, and Francis alluded to some of the costs associated with some of that, because it often costs more than actually what we're budgeted for, because agency is more expensive, for example, or overtime is more expensive than people in post. So those are the two numbers. So a year ago, 3,040 establishment, 2,670 in post. Currently, we've got about an establishment of 3,325 and 2,897. It'll change every day in post. So you can see that what we're doing is we're growing the number of staff that are in post, but we're also growing the establishment. So despite recruiting, what was that, something like 250 people last year, additional people, we still got about a 12%, 12.5% vacancy, because the establishment is going up broadly at the rate that we're recruiting. So it's not that the people are leaving and we're not filling them. We are filling them more so, but the establishment is increasing as well. And I just want to give people, sometimes people, it's important to understand the size of that task really for the people doing it. So we recruited about 250 additional people, and because of turnover, around about 300 people will have left. So last year, the HR team will have recruited something like 500, 550 people. So that's, if you think how many people would have applied, thousands of people would have applied for those jobs. They all needed to be shortlisted, check their CVs out, interview panels arranged, people to be interviewed, appointed, check their references, check their passports, visas, etc., do their DBS checks and all those sorts of things that are going on. So you've got this constant churn of recruiting, that number of people every day. And sometimes, it's just important to appreciate the stuff that goes on behind the scenes to keep those people sort of running on the spot. So that's the stuff about establishment and staff in post. And then the other thing I wanted to touch on was we looked at the gender pay gap report. So this is a legal requirement that sizable organisations every year have to report on their gender pay gap. So the gender pay gap is the difference in the average wages of men in the organisation compared to the average wages of women in the organisation. So this is not equal pay. So a male nurse with 5 years experience doing the same job as a female nurse with 5 years experience will get exactly the same. That's equal pay. This is just looking, if you take the average, the earnings of all the men and average it, and the earnings of all the women and average it, you get a gap. And for us, that gap is about 11.5%. So on average, men are earning 11.5% more than women in the organisation. They get the same pay for the same job if they're doing it, but on average, that's there. Now, in the NHS as a whole, that gap is about 15.5%. So we beat the average on that we've got coming through. And then we're having a look at, what the reasons that might be. So interestingly, about 78% of our staff are women and 22% are men in the organisation. And if you look at the lowest earning group, so the lowest quartile, for every 4 women in that lowest quartile, there's 1 man. And then if you look at the highest earning groups, for every 2 women, there's 1 man. So when we look at the high pay, basically the upper quartile generally reflects our workforce. So it's 3 and then 1 for a man. So about 3/4 of women in the highest compared to about 25% of men, and then in the lower pay. So we see that we've got an issue there in the gap at the low pay. And then we're looking at, so what are the activities that sort of drive that? Why is that the case? And some of that is societal. Women tend to take breaks from service. They don't go for promotion because they've taken time out to look at their families. So they tend to not progress up the scales equal to the men. Some of the, things like domestics are dominated by women. Those are lower paid sorts of groups. that we've got. But we have a look at that both in terms of, how do we increase people into those higher pay scales, but also what can we do at that lower end as well. So those are just two concepts. I think I just because we're going to do this for a period of time, I thought it was really important that people got that. When we talk about vacancies, what do we mean? And is that difference between the staffing post and the establishment? So I hope that's a useful way in. But again, like the others, happy to take any questions. Thanks, Caroline.
Thanks very much, Dean. I think that's been really interesting from our chairs to hear some of the work they've been doing, and probably useful for future meetings to sort of update on some of those areas you're looking into. And of course, we're going to have a similar standing item at our government development days as well, where we probably have a little bit more time than we've got today to explore some of those issues as well. So thank you. I see Tony's hand up, and please put your hand up if you've got any questions at all. Tony.
Thanks, Caroline. Dean, I've two questions. Firstly, you mentioned about you've been looking in more detail why staff leave the organisation. How has this been assessed in terms of reasons for leaving, please?
Yeah, so we have two sources of data, Tony. So there's a system called ESR, the Electronic Staff Record, that when people leave, we record that by a code, or the organisation records that by a code. So we for the majority of people, we've got a reasonably good idea. It's quite broad, but it gives us a reasonable idea. And then we also do exit interviews, which I'll sort of come on to. So we capture a proportion of staff to do a more detailed discussion about why they're sort of leaving. So, for example, on ESR, there isn't a code that says I didn't get on with my manager, that sort of thing. But we know that some people may leave because they don't get on with people in the organisation, and we need to see if that's clustered or those sorts of things. So yeah, so in terms of those reasons for leaving, the largest category is retirement. The second one after that is work-life balance. I'm doing this from memory now, and then I think the third one is promotion. So if you look at those, then it's what can we do about that? And I think promotion and work-life balance. Can we get in a bit earlier to correct some of those ourselves? Are there promotion opportunities that we could have brought to people's attention sooner, or could we have done something with the job? Retirement, generally speaking, I think when people decide, they decide. But we can have a look about, would you like to come back and work on the bank, or reduce your hours, or phase into retirement? And some good work goes on through the HR teams and the ops teams to try and capture those. But those are the if we can reduce that turnover, that growth becomes quicker, if you see. So less people that leave, if we can still keep on recruiting at 250 and less are leaving, we grow it a little bit faster than we are doing.
Okay, that's really helpful. Thank you. My second question is, you mentioned the fact that the establishment's grown and we're recruiting more staff. Now, I think the key to this is, are we recruiting to the difficult to fill posts, i.e. consultant posts? Thinking about the number of agent, locum consultants we have, just as an example. Or is it where new services development is more interested in it? That's where the growth is coming and the recruitment's happening, not to the hard to recruit posts.
Yeah, absolutely, Tony. And we have a report that comes to the workforce committee that's called the hard to fill recruitment task and finish group, as it were. So we are looking at things like consultants and registered nurses in there. And over the last year, both of those have grown. So our registered nurse staff in post has grown. From memory, Francis, by about 40. I've not got the report in front of me, but 40 net growth over the course of last year, and the consultant body has grown as well. So we've appointed 2 consultants and some GPs. Some of the things that we look at around those, Tony, is with some of the long-term consultants, is there's a little bit of art in that. As you'll appreciate, some specialist posts. You sometimes have to be a bit careful about advertising for something if it's not there, because it may be that the decent locum that you got in place that's doing it might think, well, if they're going to be filling it, I'll go off somewhere else. Thank you very much. So there's a little bit of art and science, I think, in those. But yes, we do have a focus on those hard to fill areas. I saw Michelle's hand popped up. I don't know if she'd wanted to say more on that, but.
Yeah, I was just going to say these are executive questions, to be honest. I mean, let's just remind ourselves that there's a there from the assurance. No, it's all right then, Tony. I just think we've got some new governors around the table.
Right.
You know, these are, you know, the assurance report. So how are the non-executive directors getting assurance in relationship to the executive work? I think Dean's obviously explained it very eloquently, but I mean, I'm more than happy to cover some of that either in the development session or answer some of the questions if after the assurance report. But there is a task and finish group called How to Fill Recruitment. So we've got the recruitment group. We've also got a specific one on how to fill posts, and that's where we look at golden handshakes, incentives, how we develop the unbelievable recruitment campaign that we started across the organisation, and then all those conversations come into the executive management team, and we make the decisions in relationship to how much finance it is, cash, etc., but also figures and numbers. There is an issue, as you rightly point out, Tony, with a lot of transformation going on and a lot of new areas developing and a lot of new services opening, that the staff can tend to migrate into those, you know, wanting a different experience. So we've tried to mitigate a bit of that, because I think we're quite an unusual organisation. We have what's called a transfer window for staff. So a couple of times a year we do a staff transfer window where staff can stay in their post technically, but move into another role and see if they like. It's a bit like dipping the toe into the water, but then it also allows us to look at where the potential volatility is and the movement. The other thing that we're doing is obviously alongside international recruitment, but we're starting to work closer with our provider colleagues to see if there's something that we can do, a collective, because some of them are really hard to fill posts, and not just from within our organisation, but then what you end up doing is just increasing the incentives, and then somebody else will increase it and somebody else will increase it, so it becomes a bit more of a difficulty. So lots going on, which I'm more than happy to talk through. I hope my sound was all right as well.
It's fine. Thank you.
Fine. Thanks, Michelle. Will.
So I hope this is the right place to ask the question, but I was interested in, I think, what was it Mike was saying about quality and the, was it quality board or quality dashboard
Quality
or something?
committee. Yeah.
The
quality, the QPAS.
And I was sort of reflecting and sort of also looking at the performance indicators. One of the things that I've kind of raised in my career and wonder about is we've got the number of incidents as a measure of quality, but I've never found a definition of what is a DATEX and when it gets de-escalated, because I know you can put it as DATEX and then it'll get de-escalated, but what is when it is a DATEX and what is the threshold for de-escalation of a DATEX? I don't think it's consistent, and I wondered if there is a measure of that or a definition of that, because that might affect what those reports actually represent.
Thanks, Will. Mike, Michelle, or Pete, does someone want to pick up on that?
Given an outline, of the process in terms of DATEX and how it goes to the corporate safety huddle, and then the actions are placed on there. That's what I'm told. It's really an exec question as to what happens in terms of definition. So to Michelle, I'm afraid.
Thanks very much, Michelle.
Yeah, no, thanks for that good answer. We've got a policy, a serious incident policy that lists the different grades from category 1, from no harm all the way through to level 5, and there's a level and there is a threshold. We as an organisation, as Mike says, do a huddle on a daily basis, so we assess where that should be and if it should be DATEX, and everything should be DATEX, to be honest. We should be putting everything onto the DATEX system, near misses, everything, because the more we record and the lower end of that severity rating, the more culture we've got in relationship to patient safety. So we should be DATEXing everything. We've also got a grade text system as well, where we put in things that have worked really well and where we've got some really good practice. We generally escalate them up to start off with, and then we tend to do what's called a 72-hour report. So we'll get all the information together, and then we'll look and see where it should sit, whether it should continue with that 72-hour escalation process and go on to be a full-blown investigation, or whether we just need to regrade it. So it's really, once we've got the data, then we'll have a look. But we tend to always err on the side of being higher and bringing it down rather than being lower and then escalating it up. So it's usually after the 72-hour report, but we'll send around the policy so people can have a look at it, but it's done in that safety huddle. But everything we should be putting onto Datex, it's not just there for things, it's for near misses, anything that you see, whether it's got no harm all the way through to the severity ones. And you'll see that through the report, that we're actually getting a lot better at recording everything. And likewise, we're getting a lot better at recording things when things go really well as well in the grey text system. If that makes sense. Is that helpful, Will?
It is.
It's nodding.
It is.
It's nodding.
It is, absolutely. But I suppose my reflection is I've always got different answers from different areas of the trust when I've asked. But that's a very useful response. Thank you.
It's the same process, and the corporate people out there, there's lots from different areas as well. So it's not just that we're choosing one area, it's the whole combination of everything.
Thanks very much, Michelle. Mike, sorry, did you want to add something there?
Just wanted to add in if I can, and risk of teaching me grammar case, but for the new governors, well, all of the governors hold the boards to account by holding the performance of the non-executive directors to account. And I just wanted to outline what I would be looking for as a non-executive director in terms of this reporting, and very much what Michelle has said. What I'm looking for is 4 words: high reporting, low harm. So what I want to see is the number of reports increasing, but the number of harm incidents decreasing or remaining stable in terms of a numerical value. So that's what I'm looking for. And in my time during the trust, I think we have that reporting culture, and you can hear from the Chief Executive how strong she is on this.
Thanks very much, Mike. Thank you for those questions. I have not seen no other hands up. So this is our first opportunity to have this as an item on the agenda. Obviously, we need to try and make sure we get the balance right and the understanding right about what the chair NEDs are responsible for and what is the operational executive side. But I think it's been a useful outing for this item on the agenda today, and I'll take that away and talk with colleagues about how we might put this together for the next one. And any views for you on that, please let me know and email me. But I think that was a really helpful first outing for this new standing item on the agenda. Thank you, chairs. Thank you, chairs of subcommittees, and thank you, Michelle, for the rigour of the executive backup there as well. Thank you very much. Okay, moving on then to government development proposals. Now you'll have the report that I've put together, and the history of this is from pretty much the beginning of this year, some discussions that I was having with different governors, particularly coming out of, well, I say coming out of the pandemic. It is still with us, and obviously Michelle mentioned about the COVID infection rates going up, and we're still in a little bit of a limbo about what needs to be done in terms of restrictions. However, we started a conversation about, I suppose, what recovery looked like in terms of supporting our existing and new governors, and had a look at some of the different arrangements and where we felt we could tweak some arrangements and enhance some of the arrangements as well. So this report is really a culmination of that initial discussion, which led to a working group. Thank you to all the people who were involved in that working group, who helped put these ideas together. It's been through a governor development session. The proposals, the recommendations have also been circulated around the whole trust board, both NEDs and non-executive management team members as well. And we've arrived at these proposals, which I feel they do reflect the discussions. And of course, it may be that there are, some tweaks to this down the road. But I think the report is pretty self-explanatory in terms of the areas we've tried to cover, the focus we've tried to make. And in fact, a number of these recommendations are already being put into practice. The last item is a really good example of that, and the refreshed Governor Development Day that we had recently. So I don't really want to say anything more because it's all in the report there, but we've tried to cover issues around IT, issues around what our meetings are about and how we want to use them, but also other forms of support as well, and bringing together, I think, more completely, what the NEDs do to governors, so that understanding is there, but also getting to know each other better, which has been difficult, I think, when we were in lockdown and the restrictions that we all had to work under. So I hope you will approve the report today, and I'm really happy to take any questions or comments. Any questions or comments? Duff. You're on mute, Duff.
Yeah. We did discuss this in the pre-governor meeting, and we did get a note from Tim saying that he was a bit disappointed that we weren't going to have the finance meeting. So I'd just particularly like to refer to points 13 and 14 in the recommendations, which are about the fact that we're no longer going to have a finance audit, strategy, quality, workforce, mental health legislation, governor group, and that we are going to have, as appropriate, online in-person meetings, written governor briefings and short task and finish groups on specific trust issues to be provided by NED chairs or EMT. Now, we had a very good discussion about, for many new governors, understanding their finances is a big challenge. And because we don't want to spend huge amounts of time on our governor meetings looking at that, it might be a good idea to say, so this is an example exploring how the paper works. Some of us would like to suggest that we have a briefing on the annual report so that the governors get taken through the annual report so that we get to understand the finances and we get to understand the quality issues in terms of how those balance with the finances. And that would be a kind of training development opportunity that I would potentially look to Stuart and to some extent to Francis, supported by the executive team, to just ensure that particularly the large number of new governors we've got have a chance to really understand the paperwork related to the finance, and that we could do that without having to have a finance committee. Now, how would, in this new arrangement, how would we trigger that request?
It seems to me, Dolph, I mean, I think we can just basically, you've made the request and we can go away and think about how we could fulfil it. I don't think it's, I see that during your contribution, both Francis and Stuart were nodding their heads. And I think that fits very well with, the recommendation is that, there should, by not having these governor groups, and just to add to, one of the reasons why, after some discussion, this included from governors themselves, about why this group should stop, is often they were overloaded with a number of different items, particularly the one that dealt with quality mental health workforce, but also attendance wasn't that great. And that's not great for the governors who do attend, but also it's not great for the NEDs and others who take part in it too. But I absolutely agree with you. And why don't we just take away that recommendation, and then we can come up with a proposal of what form that should take and how we will make sure it happen. I mean, I think potentially, and I don't want to sort of, we can go away and discuss this, an annual opportunity alongside anything else that people might want to raise in other forums around finance in the organisation. An annual opportunity to go through exactly what you said would be quite a good way to do this, and maybe for those who who can't participate, some sort of written explanation or something like that. But I think let's take that away, and maybe if yourself or another governor wants to be involved in agreeing what that form that should take, that would be really helpful. I can see Francis.
Yeah, just to support that and say we did do something along these lines. Pete put together a really good finance teaching session. So again, if governors let us know what they want, then between Pete, Stuart and I'm sure we can do a similar and develop that. But it was a really good session that we had on a Governor Development Day about 12 or 18 months ago, I think, Pete, from memory.
Pete?
I was going to just say that, Caroline, we could rerun the Governor Development Day with the introduction to NHS finance, how it flows, difference between cash and capital, accruals and cash et al. And we're probably looking at putting some workshops on for wider staff groups through finance as part of the Humber Financial Times and feedback we've had. So again, governors would be more than welcome to drop into those sessions, and there'll be sort of like different themes every other month.
That's great. Does that sound to Doff and other governors an action to take away and make progress on? Brilliant. And of course, Pete was at the induction yesterday, explaining some of this accruals and what have you to new governors then. Okay, brilliant. I can't see any other hands up. So does the Council of Governors agree to approve the Governor Development Support Report and its recommendations? Yep. Fantastic, thank you. And we'll get on that. And the last recommendation is we'll bring an action log back to Council of Governors meeting to show what progress is made until we've met all the recommendations. Brilliant, thank you so much. Sue, we're over to you for the Appointments, Terms and Conditions Committee Effectiveness Review. Sue, over to you. Sue there? I can't hear Sue. I'll tell you what, if Sue pops up, let's come.
I am here. Yeah.
Brilliant.
Technical.
Sue, over to you.
Thank you, Chair. Yes, the annual review of the committee, the Appointment Terms and Conditions Committee for the Governors, as you can see, has been attached in your packs. We have done quite a lot of work this year with regards to extending governors, appointing governors, extending executive directors, non-executive, and appointing non-executive. Part of that does marry in with the work plan. We've approved the extension of Mike Smith for 2 years and the reappointment of Dean Royals, and that fits in with the looking at the work plan, because a number of the non-executive directors were due to finish at the same time, and that doesn't help with going forward. So we've done that. We've appointed Stuart McKinnon-Evans as a non-executive director and as chair of audit. We approved the extension of Peter Barron, which has now finished, non-executive director chair, so that was just to help Stuart to settle in and to understand the workings of the trust. That, as I say, married in with the succession planning for the non-executive directors. Going forward with that, we've also appointed and just been approved prior to this meeting in the private governors meeting, the appointment of Philip Earnshaw, GP, to non-executive director with clinical overview, and he will be taking on the quality committee, and we absolutely thank Mike for chairing that up to now, and I'm sure he'll help Philip to settle into that as well. Also, since this report was done, we have appointed Francis Patton as the Senior Independent Director, and he's taken on board that for 3 years. Thank you for that, Francis. We have looked at Francis and I undertook to do the appraisal on chair, Caroline Flint, and that was all undertaken and that went forward, and that was, I think Francis will agree, that was quite a good process, and that has now been ticked off. Caroline and I have undertaken a review of all the non-executive directors, done their appraisals. That will be going forward with Caroline and I to do a formal report on that, and I think we're meeting sometime soon, Caroline, for that. And we will be feeding that back to the governors as per the work plan, which will be in September of this year. So your governors will get to know the appraisals of the non-executive directors. Going on then to the work plan, we have tweaked it a little bit to try and make it a little bit more effective and to make things be correlated together so that we're not having to have lots of meetings just to discuss one item. So in September, we will be doing the balance of skills, knowledge, experience and diversity for the non-executive directors. That ties in with looking at the succession planning. I'm hoping we will have a table. We'll be able to come out with a table then of when all the non-executive directors' terms of office are and that should help for us to see all of that, and that fits in with the feedback as well. We'll be looking at the succession planning for chair as well. We'll be discussing that. And as I say, evaluating the reports on their performances, and we will be bringing that back to Council of Governors as and when we've prepared that, but it will be September, October, I think. And also going on from that, I think you can see that that's quite a lot of work being undertaken with regards to reviewing, appointing, extensions of times. And I thank everyone on the committee for helping with that. Talking of the committee, and you will see that attached is the terms of reference, which does need looking at. We did look at that earlier this year. It was agreed by the Appointments, Terms and Committee meeting at our last meeting, which was the 23rd of June, hence not being included on this report. But we will be reviewing that in May of next year, and May has fallen off the end of the annual plan, but believe you me, there will be May in 2023, and we will do that. And I just think we will need to look at the work plan so it does flow a little bit easier, because some of it's on the back, and I think we could reduce it in some way so that it, you know, we can look at that. But going on with the committee, if you do look at the terms of reference, we are allowed up to 4 public governors. At the present time, we do have 2 public governors who attend frequently, myself and, you see, that's just gone out my head. I do Helena Spencer, which is great because Helena's kept up to date with me as well in case for any reason I can't be there. But it does say we can have up to 4, and I would just try and ask any of the new governors to have a good look at what we do on the appointment terms and conditions and maybe put themselves forward for that as well. Because if you've got to have 2 for quorate and for any reason Helena or I are not, then we actually fall short, of course, and you know, we then have to have, you know, emails flying around and all that sort of thing. I just think we could be a little bit better than just the 2 of us now. We have some new governors, so I hope you don't mind me saying that. Also, as I said, when we go to do the we'll do a resume of the profiles for the NEDs is due as well, and that will be prepared for governors when Philip Earnshaw has been in post. And that ties in with doing the table of when all the governors' terms of office will be. And I think we'll be able to give you a lot more information before the end of the year about how this committee works, and a bit more on the work plan.
Thanks.
Questions?
Thanks, Sue. Any questions to Sue? No, thank you. That was very comprehensive, Sue. Does the Council of Governors approve the Appointments, Terms and Conditions Committee Effectiveness Review? Any objections? No, that is approved. Thanks very much, Sue. We move on to Governor Group's feedback. Obviously, we've just heard from yourself, Sue, about the work of the Appointments, Terms and Conditions Committee. So I don't know if there's anything else you have to add. I think that was pretty comprehensive before. So if it's okay with you, we'll go on to Doff in terms of the Engaging Members Group. Doff.
Thank you. We met, and our meeting very much focused on the annual members meeting. We did talk about other things. As a group, we've really looked at how we communicate with members, and we've looked at every action counts. And what that's done is very much had the idea that the work of the governors and the members links very closely with the work of the Patient and Care Experience Forum, and also with volunteers. And all of those people can be members, and we can communicate with them across the piece. And so we're working in our plans for our presentation at the AMN, and there has been some, as Michelle has said, the regulations about how many people we can have will potentially go up and down according to what the advice is for COVID. And we did start off with understanding that we were going to have quite a bit of virtual activity. So we've made a proposal that we have short films that cover volunteers, patient and care experience for being a governor and what being a member means. And I'm in discussion with the communications team about how we can put together something quite short about what being a member means. We did talk about the fact that as governors, our big role is to find out what the public think and to use that information to feed it back into the trust. And so we're proposing that all governors have a very active role at the AMM, that we're well badged, that we help and support the organisation of the event, and wherever possible we can be involved in manning tables and being very proactive at talking to people who come to the event who want to know more about the organisation. So would-be members or members who've chosen to come because they're a member and they've had an invitation. So we've made quite a bit of detailed progress around that. I've had an email exchange with Michelle today, Michelle Hughes, and we are proposing that we will just have a short meeting, one subject meeting, and we're going to bring our planned meeting from the 1st of September forward to the middle of August, because I'm not going to be here on the 1st of September. And we'll go through with all the governors who are interested, and that'll be a really good opportunity for governors who want to come and find out about the members group, and to ensure that we make a very good showing as governors at the annual members meeting. So I'm open to questions.
Thanks very much, Doff. Any questions to Doff? No. Okay. Thank you very much, Doff. Responses to Governor questions. We haven't received any questions. I did have some sort of exchange with Brian earlier this week about some questions about the performance report, which I've answered some, and I think Lynn might be coming back, and of course we've got Pete next. If governors have any questions specifically that they want to be answered at the Council of Governors, please send them through. But you can ask your questions in the meantime to myself or to the chairs and Eds, or to our members of our EMT, who will try to help as much as possible. If there's something you don't understand or you want clarity on, please don't hesitate to get in touch. Okay, we're moving on then to the performance update. Pete.
Thanks, Caroline. So this is the Trust Performance Report, which takes us to the end of May. For the new governors today, just for completeness, we present our performance data using what we call statistical process charts, and we pull out performance for those indicators within the body of the report that fall out of what we call normal variation. So you'll see in the graphs we have upper and lower control limits. I'm not going to spend 20 minutes now talking about statistical process charts, you'll all be pleased to know, but it may be one for a future Governor Development Day, Caroline. Lee's been in the past to do it when we first brought it in, so it may be one for a future Development Day. For those of you that have seen the reports before, you'll notice that in the incidents data, we're now introduced a new chart into the report, and we're reporting incidents per 10,000 contacts with supporting information at divisional level. So that makes it a bit more of a true judge of incident reporting, because you can link your number of incidents to the amount of activity you're dealing with. So it makes it a more meaningful data source. I guess some of the things I'd pull out and the narratives in the report, areas of what I'd call concern are on the safer staffing dashboard. You'll notice the fill rates and sickness are areas that we pull out as areas of concern, but equally on the safer staffing dashboard, we get positive assurance on our care hours per patient day. We'll also note that sickness is quite high across the trust, and we have got a number of things we've got in place for staff to help them come back to work, stay in work, or actually make sure that our units are safely staffed. So Dean mentioned earlier about the level of vacancies and the spend we have at trust on bank, agency overtime, etc. I guess to keep it balanced, as I always try to do, we have got some positive assurances in the report as well. So I would pull out the strong performance we've maintained on mandatory training and clinical supervision. And clinical supervision is in the context of a target we increased at board earlier this year. And as Michelle said earlier, we have seen a continued improvement, reduction in the use of out-of-area beds. So that did peak during the pandemic due to obviously COVID and reduced bed capacity, but we're now seeing an improvement in that trajectory. There's detailed narrative in the body of the report on waiting times, which I won't read out to people, but what we have included in the report is referral activity, because I think it's important to correlate referrals to waiting time so we can see that demand for services are rising. I am conscious of time, Chair, so I'll stop there. I'm happy to take any questions. And if I can't answer it, because I know Lynn's not here today, I will take it away and provide a response outside of the meeting.
Yeah, thanks very much for that, Pete. And I think actually governors are due a sort of update briefing on some of the issues around weights for assessments in terms of neurodiversity. So we can do that as a briefing in the way that we described earlier for colleagues. And I know Lynn's ready to do that. Any questions to Pete? Will?
So I think it's one I've wondered about. So the clinical supervision, which staff are counted as requiring appropriate clinical supervision, and is it clinical supervision in line with our policy, or is it just have had some sort of clinical supervision?
So,
Pete?
I think it's clinical supervision in line with our policy, Will, but I will clarify that with Hilary, who's not here today, and I believe it's qualified staff, but I may be wrong.
Okay, Michelle, can you come in on that, or should we follow that up?
Yeah, it's clinical staff, as Pete said.
Right. Okay. Can we follow that up for you, Will, and share that with you? And we'll when we get the answer to that, if Jenny, Katie, we can share that answer to that question with all the governors, so they're all across it. Thank you, Brian.
Thank you for the report. I found it very enlightening, actually, and very well presented. I have raised a number of questions already with Caroline, but there's one or two minor issues that I'm still a bit unclear about. Obviously, I think we're all concerned about the long waiting lists for patients. But what I'm interested in is what sort of proportion of referrals do these waiting lists represent? Is it, it's hard to know how we're performing in relation to the number of referrals we have anyway. Secondly, I noticed that the other interesting thing I'd like to know is how our figures compare nationally, and are there some trusts that perform better, and if so, how do we learn from their practice, so what is the best practice really, and can we learn from other trusts that are achieving smaller waiting lists? Fourthly, what is our action plan to try and alleviate the waiting lists? And I know that a lot of it involves staffing, and I was very pleased to hear the Dean talk about the staffing and seems to be tackling those issues. But I wondered if there's any other strategies that can be used to improve our figures.
So really good questions, Brian. The first two, and I'm not trying to dodge them by any means, are quite technical in nature, and I would hate to mislead you today to tell you the percentage of referrals in comparison to our waiting list, or indeed how we benchmark with others, but I can pick that up with Lynn, and I'm sure we might be able to include it in the briefing Caroline alluded to. In terms of action plans, I guess for me, there's probably three elements to it. Possibly four. There's one is we're always in contact with people who are on our waiting list and offering other services while they wait for the treatment that they're waiting for. We have looked at providing additional capacity where we can get third sector capacity. Obviously, there's the ongoing work we're doing for recruitment in terms of that, and the fourth one is data validation. So the fourth is more technical and minor. The other three are what we're doing, and we'll probably highlight it in the briefing Lynn's got in the appendix to this month's performance report to the board, but equally what we're planning to send around the governors.
Thank you.
Thanks, Brian. I'll tell you, we will, as I said, we'll take both Will's question and your questions, Brian, and where we can find some answers, we'll put them together and circulate them around the whole governors. But we are due for an update on some of the work being done around the assessments process and people waiting, which will get scheduled. Michelle.
Thank you.
Yeah, no, I think thanks, Pete, for those answers. I think they were really succinct, and thanks for the questions, some really helpful. What we could do is when the waiting list reports come to board, we can circulate that because it's quite a detailed paper that will answer a lot of those questions. To be honest, in relationship to best practice, I lead the mental health and learning disability and autism collaborative for the integrated care system, and also do a lot of work nationally. And suffice to say that we are probably one of the organisations that's leading some of that work in relationship to use of digital, the way that we do our referrals and the way that we keep contact with patients that are actually on the waiting list, and the work that we particularly do in schools if we're talking about children and young people, because we do a lot of work in schools with special educational needs, but also with teachers, and that's growing across the patch. It is a real national issue, is the waiting list, and it's to do not just with workforce but actually with funding. And how the funding's been divvied up in relationship to the recovery piece. We have had some extra input to that, but there's still obviously a shortfall with the numbers coming through. Not just with COVID, actually, the numbers were dramatically increasing before COVID. If you look at the referral pathway and the trajectory before COVID, it was really significantly on the up. And obviously COVID has been significantly accelerated that process. So it might be something that obviously Tim always asks a question about from a governor point of view, and it is obviously a major challenge alongside workforce and one of our key risks. So we're happy to continue to have that conversation, but let's send out that information first, and then we can pick up any other further comments. I would suggest, Chair, and have a further discussion, maybe at one of the development sessions.
Brilliant, thanks, Michelle. That's really helpful. I know, governors and obviously the board has taken a very strong interest in this area as well. Okay, thank you very much. Let's, if that's received and noted, move on to the finance report, Pete.
I think you've got a hand up, Caroline.
Oh, sorry, apologies. Will.
Yeah, it was just to clarify with Michelle. We do work into schools, and it's particularly around SEND, because I think they're two very different things in child. So I think absolutely we've got mental health and schools teams, and they are working very closely, but there's a high demand around SEND that I don't think we are involved in the same way. So I'm just interested, is there a clarification there?
Yeah, no, thanks for that. There is, and that's what we're looking at, is all the situation out where we can do that early intervention work, preventative, pulling them upstream work before they actually get into the system. So you're absolutely right, and that's the area that we're concentrating on. We've actually got a child and young people and adult escalation process now for waiting lists for mental health and learning disability, which is starting to look at with our partners, including local authority, how we can work collectively together better in relationship to supporting people and making sure those waiting lists stay try and reduce them. I was only talking about it in the Integrated Care Board yesterday, so thanks for that.
Thanks, Michelle. Thanks, Will, for that question. Thank you. Sorry I missed you, but I'm glad you got in. Okay, right, finance report, Pete.
Lovely, thanks, Caroline. So an unusual finance report this time because it spans 2 financial years. So very quickly, you'll see from the report for 2021-22 last financial year, the Trust met its financial planning target, which was to deliver a break-even position against our control total. So, really proud of that achievement again. I think it's the 7th year we've delivered our control total in a row since they were brought in. And as Francis said earlier, all the feedback we've had through the year-end process with our auditors has kind of re-emphasised what we knew, that we ended the year in a strong financial position. So if I move us into 2022-23, at the time this report was written, which is the month 2 position, the Trust was operating with a plan to deliver a planned deficit for the year of just over £1 million, and that was our ICS control total at the time, and that reflected inflationary pressures, non-paid pressures, and the efficiency asked from the centre. Since the report was written and the month 2 position was established, there have been some additional resources released by NHS England, and we have resubmitted a plan which was approved by our board last month, and that is to deliver a break-even position for the year. So obviously future reports to the Council of Governors will be against that break-even position. As we were at month 2, we recorded a position that was consistent with our ICS plan, and this included a provision for a pay award of 2% because that was what built into the planning guidance. So we recognise our staff haven't yet had a pay award, so we're making a central provision for that cost so that because we recognise it's covered from our income. I guess the other headlines I'd pull out just for the governors are our cash balance remains strong. You know, we've worked hard for 6 years to get there, and it's good to still be in that strong position. Governors will note that the cash did drop between February and March, and that was due to the trust settling its outstanding loans it had on its balance sheet. Again, that's a really powerful thing and a really good achievement. It increases our capital headroom. It washes its face financially from a revenue perspective. And I now believe we're the only trust in Yorkshire and Humber that don't have any loans on our balance sheet. So a really strong position to be. And then the increase in cash that has crept up from April is mainly due to the payment process for the lead provider collab, which have moved from a block transfer monthly to an invoice between systems. So a whistle stop tour, Caroline. I'm happy to take any questions on the finance report.
Thanks so much, Pete. Any questions to Pete on the finance report? No, that was all really clear, Pete. Thank you very much for that. We move on then to the fit and proper persons compliance report. This is really for information. It went to the board, and basically it's make sure we're satisfied that both executive and non-executive director posts or anyone performing similar or equivalent functions are fit and proper persons and meet the regulation. And I'm pleased to say we all do. So that's come to you for information. Any questions on that? No, thank you very much. Public Trust Board meetings for March, April and May to receive and know. Any questions on those? No, thank you very much. That was received and noted. I haven't been given notice of any other business. Any other business from anybody else? No. So suffice to say, we've come to the end of our proceedings for this afternoon. Thank you all very much. Oh, Sue, you've got your hand up. Did you want to say something? You're on mute, Sue.
It was just for the end. I did it. I was presumptive. I was going to do it when you'd finished. Just to say, I do apologise to anyone who's sending me emails because I do not have the wherewithal to be answering them. The trust have been very good and let me come in and use the trust equipment last week for a meeting and this week, and hopefully going forward next week I'm coming in, I think next Thursday, to do the emails. I've got quite a few to answer. I just wanted to apologise to anybody I can't get at them at the minute. Technical.
Thanks, Sue, for that. And you know, I'm sure we're all very patient because you do so much. And we could hear that earlier on in terms of all the things you've been involved in. So thank you so much. And OK, so for those of you who are new governors, and this is your first meeting, I hope you found it helpful. There may be questions that have come out of this which will occur to you later on, and you'll think, oh, I wish I'd asked that. Please, get in touch. If there's anything that occurs to you, you think, I wish I'd asked that, or I need some more information, you don't have to wait to the next time we get together. Please just get in touch. I thought it was a really good meeting. I think it was a really full meeting, and thanks for all your questions and observations. And I look forward to seeing you all very soon. So look after yourselves and thanks very much.